Ma'am, we are about to be live in a minute. If you can please turn on your camera. Ma'am, are you there? Hello? Hello?
I'm there, ma. Just 1 second.
Okay, okay, ma'am.
Listen.
All right, ma'am. If you can please turn on your camera is not on.
No, 20 seconds.
Ma'am, are we good to start? With all your due permission, can we begin?
Just a second.
Sure.
Yes, ready?
All right. So with all your due permission, we are beginning with the session for today, ma'am. Good
Yes.
afternoon, everyone. This is Batul from IGCP, and I would like to welcome all the viewers and all the participants who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. Ma'am needs no introduction, but it is my honor and pleasure to introduce her at our platform for this particular topic that she's going to talk about. She's none other than Dr. Tripura Sundari, ma'am. Ma'am is a very renowned gynecologist and obstetrics. She is MD, DGO, FIMS, consultant and HOD at obstetrics and gynecology at Keams Hospital. With the help of ma'am, we'll be taking a close look on today's topic, which is postpartum hemorrhage. Before moving on to today's session, let us have a brief look on what the topic says. Postpartum hemorrhage is a complication of delivery and a cause of maternal death that accounts for more than 35% of all maternal deaths worldwide. Uterine atony is the most common cause of PPH. According to the World Health Organization, mild PPH is defined as a blood loss of 500 ml or more within 24 hours of delivery. And severe PPH is defined as a blood loss of 1000 ml or more during the same time frame. We'll be knowing more about this topic from our keynote speaker, Doctor, for today's session. Now, without any further delay, I would like to welcome ma'am at our platform and would like to hand over the session to her for her talk to begin. Ma'am, over to you. Please proceed.
Good afternoon. I'm very happy to meet you all on this platform. And today, as she said, we are talking about a very common and very dreadful problem, that is postpartum hemorrhage. Pregnancy is a happy thing. Everybody is, distributes sweets and very happy to have the baby in the family. But if it ends up in a catastrophe like postpartum hemorrhage, everything is devastated. A mother is lost, a child is becomes an orphan, a husband becomes the whole family loses a thing. So our aim should be not to have any excess bleeding at the following delivery. 1 minute. It's not moving. Correct. Move again. Move. Sorry for the this thing. So welcome. This is the place where I'm working, the Kim's Hospital.
Ma'am, sorry to interrupt you. If you can please make it full screen. It is not in full screen, ma'am.
It's not moving when I make it full screen.
Yeah, that is the one. Right. Click on that. Yeah.
Now
Just towards the right hand side, there are 3 arrows there. Yes, there you go.
Greetings from Kim's Hospital where I'm working, and I welcome you all to beautiful Hyderabad, which is famous for its bangles, pearls, and the beautiful this thing, lakes here. See, we all lost a very talented lady, Archana Sharma, for no fault of her, because she lost a patient because of PPH. The family lost her, and the whole country lost a beautiful, eminent gynecologist. This doctor was beaten up black and blue because he lost a patient while treating, and it was not his fault. And hue and cry, candles shouting, doctors were harassed, but this is not going to help anyway. So we should be very alert and try to treat the patient so that she doesn't get any PPH. PPH remains a major cause of both maternal mortality and morbidity. WHO estimates that 5,29,000 maternal deaths occur every year, and out of this only 25%, more than 25% take place in India itself. 2/3 of maternal deaths occur after delivery, PPH being the most common complication reported for maternal deaths following delivery. So what is the solution? We should now try to know what is the definition of PPH, risk factors for PPH, a list of causes for PPH, and how to prevent PPH. As already been told, bleeding more than 500 ml following vaginal delivery or 1000 ml following cesarean section is called PPH. And it's mild PPH at less than 500 and 1000. And similarly, if it is 1000 for a following normal delivery and 2000 cesarean, it called severe PPH. So constant drinking of blood of delivery is sometimes missed, and by the time we realize patient is in very bad shape, she loses sufficient blood so that hemodynamically she is unstable. So it should be most unpredictable thing. You should be prepared. The common cause of 4 T's that are called is according to frequency, tone, that is 70% of the causes, that is atonic PPH, trauma, there is cervical tear, vaginal tear, uterine rupture, 20%, retained product, retained placental bits is 9%, and coagulation defect is in 1%. So out of all this, if you see, the main cause is atonic PPH, which is tunes up to 70% of the cause of PPH in the delivery or following delivery. So as again, if you see, the abruption, atonic and uterine atony, placenta previa, abruption placenta, cochlear uterus, ultimately DSE. And again here, the uterine atony is the major cause. What are the risk factors? Preeclampsia, nulliparity, multiple gestation because uterus is over-distended. Previous cesarean section is a common cause because it may give way and may lead to another cesarean section which can cause bleeding. Prolonged labor or 3rd stage be more than 30 minutes. Assisted delivery like forceps or vacuum. Grand multiparity where uterus is over-distended and relaxed and won't contract immediately following delivery. Placenta previa, polyhydramnios. Again here the condition is uterus overstretched and unnecessary episiotomies which may bleed before you suture or get extended. So uterine atony can be muscles don't contract. Trauma is damage vagina, cervix, and uterus following forceps or vacuum extraction or a prolonged obstructed labor, retained placental tissue, and blood clotting conditions. So what are the medical conditions that lead to PPH? Already exist advanced maternal age, multipara, high blood pressure or preeclampsia, infection, chorioamnionitis, especially in case PROM is there, prolonged exposure is there, there is infection of the chorea. So this can also lead to prevent this contraction of uterus, and already existing blood clotting disorders And intrahepatic colitis of pregnancy is one of the causes. Patient comes with only itching and rash. If you neglect it, it can be a case of ICP, and these patients usually have PPH. Infections during labor, perineal laceration during vaginal delivery, especially a big baby is born. So when these conditions are there, you must have an idea that this is a patient, is a potential case for PPH, should be fully prepared for it. So risk of postpartum hemorrhage is also seen in placenta previa and accreta and abruption of placenta. Ovaries and uterus like multiple pregnancies, a large baby more than 9 pounds, hydramnios. Factors during labor is PPH and prior deliveries is there in history taking. Tocolytics were used to stop the labor. There's a case of prolonged labor, a precipitate labor, cesarean section, or under Janans. We usually nowadays we do most of section, 95% section done as spinal anesthesia. But in case general anesthesia is preferred or is made compulsory, you must be prepared that this patient can have PPH, should take necessary action. So as I told you, etiology can be hemorrhagism, infection, cardiomyopathy, anesthesia complication, others. So if you take the maternal mortality, again, hemorrhage is the commonest cause. And as I told you, for PPH 4 T's, the atonic PPH is the tone. That is the atonic PPH is the commonest cause. The most common cause of postpartum hemorrhage is uterine atony. Results of poor contraction uterus following childbirth. So the active management of third stage of labor is very important. Is prophylactically should be done. Administer uterotonics immediately following deliver the baby. Control traction and contraction is very important. Massage the uterus with fundus or placenta is delivered. This is controversial because unless if you push the placenta, it may be actually causing more of embolization. Administer uterine tonics into the mother immediately following birth of the baby is identified as the most important step. Oxytocin recommended uterotonic where the efficacy can be assured. So management, if you think of PPH, it can be medical, surgical, and you should replace the blood patient has lost immediately with the blood and blood products and fluid replacement so that the patient is hemodynamically stable. So management of PPH is first is prevention, as I told you, active management at third stage, and it occurs, if the PPH occurs, it can be medical management or surgical management. Medical management methods is uterotonics, syntocinon, carbetocin, which is a drug which has come into market in the last 2 years in India. We have been using it. Methergin, carboprost, and misoprostol. So if you think of this thing, oxytocin and analogs is carbetocin and oxytocin. Both are analogs, but carbetocin more heat stable. Here I think one I want to tell, it is heat stable up to 30 degrees. So many times in India, we have got temperature of 40 to 50, especially in summer. So not that it is totally heat stable, it is heat stable up to 30-35 degrees only. So if you are in summer, still it needs to be kept in the fridge. But it is more active, it needs to be only once, and it is as effective as oxytocin, but only disadvantage is costlier. Ergot alkaloids like ergonobin maleate and methergin, and prostaglandins is carboprost, misoprostol, and dinoprost. Dinoprostone we don't use for PPH management. We use it, carboprost we used, and misoprostol we use. So usually what we do, we give a syntocinon, 10 units into the drip, and we give 10 units IM, and you use this thing 600 milligrams of misoprostol per rectum in the, and we are trying to conduct the third stage also carefully with the thing that we want to avoid PPH. So this is called prophylaxis. So sometimes you feel it is overdone, but sometimes it is beneficial and it's not in a causes any damage to the mother. Prophylactic uterotonics are effective, and carbetocin is newer analog of oxytocin and has greater biological effect and longer half-life. One carbetocin is there, it usually, one syntocinon usually given in the drip. Once the drip is over, the action is usually there for 2 to 3 minutes. Whereas carbetocin, if you give it, acts for nearly 2 to 4 hours. So if the effect of carbetocin is there, once it is given, it can reschedule for longer period. So patient will usually recover better. It is more heat stable, as I told you. and is of crucial importance in resource setting, poor setting like our India, because in foreign countries it is all very cold and they've got big fridges. Everything is kept in the refrigerator. So, and they've got AC rooms and AC theaters. So it is useful for us, especially if we take a CHC or a small nursing home. You don't find any fridge in the labor room. So the drugs are always kept in the almirah, and when the syntosanol has to be kept, oxytocin has to be kept in that lower degree, otherwise the efficacy is gone. But compared to oxytocin, carbetocin is more stable up to 30-35 degrees. What happens if we just keep like that? You think you are given 20 units, but because it's already exposed to the heat, the efficacy is gone. So if you give 20 units, it may not show its effect on the patient. So if oxytocin is susceptible and misoprostol is there, though it is there, is useful in PPH. If it is kept for a long time exposed to air, it will absorb water, moisture, and its efficacy is gone. Ergometrin combination of oxytocin, ergometrin, and misoprostol are also available. They are used varying safety and effective profiles are equally. This is again an issue. Now, carbetocin is a heat stable. Heat stable, again, I am repeating, up to 30-35 degrees, not more than that. So it has still to be kept in a colder place. Major clinical studies seem to effectiveness is preventing PPH following vaginal deliveries, information that could expand its application for prevention of PPH. So out of all this, syntosanol is WHO is recommending, and carbetocin is, again here there is a controversy. Some started in between, they start saying, don't use methergine. I do not agree with that. Methergine is a very good drug, but thing is, in a remote place where doctors are not available, the sisters are doing the management, methergine they say don't use, because if you want to give methergine, it should be given definitely after the second, third stage, and the drug, it should be given only when the patient is not having blood pressure, and cannot be given patient having heart disease, it cannot be given patient having anemia, it cannot be given patient is having eclampsia. So these things to be excluded, only then it to be given. It may not be a place where a sister can recognize these things and give. So said don't use methergine, give only syntosanol. But given me a choice, methergine is very useful, very powerful uterine contractor, and it causes a retraction also, so that further relaxation doesn't occur, at least for next 1 hour. So methergine in the hands of an obstetrician, where the contraindications are excluded, is still beneficial. It is cheaper and very effective. But carbetocin, and as I told you, very economical also, whereas carbetocin is also good. It can be given in preeclampsia also, but it's quite costly. And doses, it should be given, adjusted slowly and given over a minute. It can be given directly or in an IV drip, well, say 100 ml, but it should be given within 1 hour, 1 minute into IV drip. And for vaginal deliveries, they say you can give IM also. But usually this carbetocin is preferred more in cesarean sections than to vaginal deliveries. Coming to surgical management, apart from the drugs, of course, as I told you, IV fluids have to be given if patient is having hemodynamic instability, and blood transfusion and blood products have to be given so that patient is well maintained hemodynamically and hemoglobin is well in level. Now, coming to surgical management, it should be suturing, and it can be conservative surgery or hysterectomy. Conservative, when you want to retain uterus, like if it is a ruptured uterus, it can be do rent repair with or without tubectomy. And or if it is atonic PPH, you can do what is compressive sutures, that is Beeling or Cho square sutures. And if ultimately, even in atonic PPH, if blood is not able to be controlled, then you have to go for hysterectomy. Now we have got in places and advanced places like tertiary care center, you can have help and do internal iliac ligation, or you can do uterine artery embolization, by which you can save the uterus. But these things are available only in few centers and they are quite costly. A place like tertiary care center, if you go to internal embolization, uterine artery embolization, it costs nothing less than 1.5 to 2 lakhs. So patient should be able to afford it, and the technique should be available, and the technician and the interventional radiologist should be available. So these things are available provided the patient has gotten access to it. So doing surgery is not the last resort, doing hysterectomy is last resort. Still, you got conservative management where you can do internal iliac artery ligation with the help of an oncologist, or you can have a embolization. Interventional radiologist can do uterine artery embolization where the bleeding stops and the uterus can be still saved. Surgically, if it is a vaginal delivery case, first thing is avoid routine episiotomy. Even for third grade or fourth grade of people starting episiotomy, the unnecessary bleeds. So routine episiotomy should be avoided. Suture properly under proper light. Attend to hematomas. Usually you think you have sutured, you come out, there is a small bleeder inside that collects the next day morning. You see the big hematoma is in the vagina, and patient is pale and she collapses. So attend to hematomas and vaginal and cervical tears, especially if it is a force of delivery, a vacuum delivery, a difficult force of rotation has been done. There will be vaginal spiral tears may be there, cervical tears may be there. Even if you precipitate labor, cervical tears will be there. So you have to examine, see, and if necessary, under anesthesia, proper light, suture cervical tears and vaginal tears so that excessive bleeding can be avoided. If it is uterine rupture, you should do a laparotomy. It can be rent repaired with or without tubectomy or hysterectomy, depending on patient's age and number of children she has. During LSCS, first avoid LSCS as far as possible. The target is actually less than 15% of the total number of deliveries, but it is touching 50% and 70% move in some places. This is, everybody is an alarming thing, but the indications and the necessity actually changes from place to place. In a tertiary case, about all VOH cases or high-risk cases, probably these cesarean sections are justified. So now actually you are supposed to give an audit as to why each section has been done, whether the trial has been given or not, whether it was absolutely necessary or not, what are the drugs given before the cesarean section, what care has been taken before the cesarean section to avoid a cesarean section. So this has to be submitted to government expertly in Telangana following each cesarean section so that they have an audit and see whether you are done properly or not. So these all these measures are taken to bring down the cesarean section rate. Because sometimes they say Muhurtam section, they say we just don't want to go through any normal delivery because my vagina is dilated, will be dilated, I want a cesarean section. These things should be avoided. This leads to primary hemorrhage, repeat cesarean section, placental complications. See, once cesarean section is done, second pregnancy, the placenta may get stuck to the previous cesarean section scar. So leading to placenta accreta, percreta, morbidly adherent placenta. You can have even the placental, scar pregnancy, like a ectopic pregnancy. This will bleed, and morbidly adherent placenta in future pregnancies common. Hemorrhage and death are the common things which are the end result of it. So cesarean section rate has to be brought down, and so that these complications can be avoided. Surgical management, tourniquet traumatic is compression sutures. You can do Beeling sutures or T-square sutures. Systematic avascularization, you try to ligate all the vessels from the side of this so that the bleeding can be stopped. Next step is go beyond that, is internal ligation. You can do embolization. These are things, the internal embolization is, as I told you, is available in few centers. And hysterectomy is the last resort. Apart from this, you should have plenty of blood and blood products depending upon the condition of the patient, and it needs ICU management. And IV fluids have to be monitored. Excess IV fluids, if the patient go into failure. So it has to be monitored carefully, and a central line will always help to see whether the patient is going into dehydration or overhydration. So what are the general measures you take? First, identify anemia, hypertension, treat hemorrhage, in the hemorrhoids in the antenatal period itself. Refer and alert. Refers and alert attending obstetrician. If you are referring patient to a peripheral, from periphery to a tertiary center, please tell them I'm sending this patient to pediatrician like adherent placenta or severe anemia or preeclampsia, so that the other doctor will be ready. And educate society with the help of field workers, media, and group discussions. Tell them about the importance of antenatal care, importance, because so many times we see, we give them iron capsules. They say, the elders in the NHK people will say, no, this will make the baby dark. Don't take leafy vegetable, become all patches on the medicine. They say they'll take 2 tablets, again they have constipation, they stop, they don't come back and tell the doctor. With the result, they'll go into severe anemia. So educated society is very important. It should be teamwork. The doctors, the patient, the attendants, and the family should all work together to save the patient. So it's a teamwork of our obstetrician, interventional radiologist, urologist, there may be rupture of the bladder, hematologist, transmission protocols, logistics, drills, post-operative care, all together only will help a case of severe BPH. So treat anemia during antenatal period, avoid routine episiotomy, actively manage third stage of labor, re-examine after completing delivery paperwork, give misoprostol 600 micrograms per rectum every woman with the risk of BPH after active management third stage of labor. So what is the role of general physician? Identify anemia, hypertension, and treat. Refer them to the obstetrician in time. In case of hemorrhage, hemorrhage disease, try to take up a help of physician. In the ICU, you have to do volume correction, blood components have to be given, ventilator support may be there. Recently, we had one patient who was on ventilator for nearly 6 days following cesarean section at PPH. We could manage her, luckily, if needed. Cardiac in case of cardiomyopathy, this is very common. In very severe case of PPH, patient usually goes into cardiomyopathy. Hematology for hemolytic anemias. Obstetricians, we know our limitations. Don't attempt high-risk cases in smaller setups, please. If it is a high-risk case, patient will say, Nene Amma, we pray for you, please do it here only, we don't want to go. Don't fall into their, become a prey to their these things. They are the people who come and hit you and beat you later. So if it's a high-risk case, don't feel bad. You refer it to a place. If you are still more concerned with the patient, go with the patient to a higher center, be there with her, conduct delivery in higher center, but don't do the cases in a smaller place, get yourself involved. Mainly the unbooked cases, they won't tell you why they have come from the other hospital. They'll just come to you, say because they said, we didn't like the doctor, we come. No, it would have been something else there. So be very careful about the unbooked cases. Don't feel bad, refer to a higher care center. You may as well accompany, as I told you, don't fall prey to the sweet bleeding patient. This is what has happened with Archana Sharma the other day. She came from a government hospital saying the facilities are not there. She didn't tell her what the problem was, and she ended a children in problem. So documentation, if possible, video counseling is a must. So video counseling may not be available every place, but there are no people are so smart. When you are telling them, they take videos with the phone. So be careful and call for help whenever necessary. Don't feel bad. Anybody, any doctor, we are all doctors together. We help each other. So call for help. No limit for experience. If you do 1,000 cases also, 1,001 case will be again a problem. Every case is a new case. So if you're in a bigger hospital, it's a teamwork. Immediately you call, you have a surgeon coming there, you have an oncologist coming there, blood flows in, anesthetist is there, cardiologist is there. So you feel safe and you can save the patient also. But in a small place, you cannot run around and you can't do it. So please know your limitations. Radiologists, when they are doing a scan in the early weeks, if it is a case of previous section, they should see the history. If it is a case of previous section, they see a placenta in the lower segment, especially in the anterior wall, they should alert the obstetrician. The obstetrician should keep this in mind. Thus, these are the cases you can go for adherent placenta. Serial follow-up is very necessary, mostly when the case of previous section. And chance of placenta previa, morbid adherent placenta are more common. So radiologists do play a role. We do a Doppler, they can tell if it's adherent placenta or not. has come to public, avoid early marriage, delay pregnancies, especially interpregnancy intervals, regular antenatal care. Please follow the doctor's advice. Public forums, Anganwadi workers play a major role, so you have to educate them. So there is always hope and always despair. If you follow the protocols properly, nothing will happen. PPH still remains a major cause for maternal mortality and morbidity. Uterine atony is the most common cause. Carbetocin is a new drug which is long-acting. It's better than oxytocin, and carbetocin is a promoting agent. It is not inferior to oxytocin, but it is better or equally good. But thing is, it acts in a longer period and it is heat stable. So it will, when it kept at room temperature, when at least at below 30, its efficacy is not lost. New formulation good stability at degrees temperature. It is currently licensed. So we all sit together, talk, we clap our hands, but it is very important for us to follow the protocols, know our limitations, explain the patient and mainly the attendants. Even the patient attendants also don't make any but it is the Bazuwala who comes and tells all things. So make it a written documentation, especially when case is bad and when there is a PPH. And you know, this is a case of patient may go in PPH. Beforehand only you tell the patient and take a written consent. So it is group work and we all should work together, and then you can definitely save the patient. Thank you.
Thank you so much, ma'am, for your comprehensive talk and such wonderful insight that you have shared upon the topic.
I think I am within time.
Yes, ma'am, you're absolutely within time, ma'am. You're absolutely on time. So we
topic. It's a huge topic, but I just want to touch the important things.
And you have done complete justice to the topic, ma'am. Whatever points you have touched, you have completely talked about the justice. So thank you so much for doing that. We have received few questions from the viewers. I would like to put it across to you.
Sure.
The first question is, does cesarean incisional site hematoma contributes to recurrent secondary postpartum hemorrhage?
Yes, we had quite a number of cases where patients were referred to as continuous bleeding. Even after 3 months or 4 months, patient had continuous trickling. And a few cases when we did, the scar hematoma was there. We had to reopen and take out the scar hematoma and resuture the previous scar. So this suturing uterine scar with single line or single layer is definitely not recommended, and 2-layer suturing should be done, because that in between some 15 years back we started doing that single layer. Again we all stopped, and I request everybody to stop that, because that is causing hematoma. And not only that, in future also, those are the cases which usually give way. The scar dehiscence and scar rupture are seen mostly in cases where single layer suturing is done. So scar hematoma is a more common thing. You should keep that in mind. Good scanning, a transvaginal scan will definitely show that there is scan. Really, actually, we operated on a case of isthmosele. She was also a case of L2, 2 previous sections. She was having spotting, section done nearly 5 years back, but she was irregular periods. So this patient, when we did scan, he showed as isthmosele. So we have vaginally repaired the scar, previous scar. So scar hematoma, scar giving way, scar isthmosele are common.
Thank you so much, ma'am, for answering this question. We'll move to the next question that we have received. And this question is, how does fluid resuscitation helps in the treatment of PPH?
PPH, see, when the patient is having heavy bleeding, there is toppling of the blood loss is there. So unless you keep the blood volume properly, she will not, first thing is the oxygenation is not, little oxygen, RBCs are there, not properly circulated. So if the patient fluid balance is not maintained, so patient will go into renal shutdown. So the fluid balance has to be kept with the before you get the blood, and you cannot give totally all blood cannot be, even all fluid cannot be replaced with blood. So you have to give IV fluids, especially the electrolytes have to be given. And if you have a acid-base analysis in this thing, you know which to give, which not to give. So IV fluids have to be given to maintain the circulation.
Thank you so much, ma'am, for answering this question. We will move to the next question that we have received. And this question is, what is the role of tranexamic acid in the treatment of postpartum hemorrhage?
Actually, we are giving before we start a section also, they say give tranexamic acid, the amount of bleeding may come down. So tranexamic acid, to some extent, it is useful. It is not totally documented, but we are still using, especially when there is trickling is there in the, when you're suturing, when you're this thing, though she is not having any bleeding dashes, we do, I use tranexamic acid. I may say probably empirically, but it acts. Especially when there is irregular, spotting is there, oozing is there, we do use tranexamic acid IV. Or sometimes put in a drip also, that acts.
Thank you so much, ma'am, for answering this question. We'll move to the next question and the last question for today's session. And the question is, what are the contraindications to surgery for postpartum hemorrhage?
Pardon me, surgery? Repeat the question.
Yes, the question is, what are the contraindications to surgery for postpartum hemorrhage?
See, surgery is actually last resort. As I told you, the patient is saying vaginal tears, cervical tears, surgery is a must. There's nothing like contraindication. Only this patient general condition is bad. As I told you, it should be in a major hospital where a good anesthetic facilities, ICU facilities are there. And if it is needed, if not controlled with medical management, and that's all also you should know the limitation. Just keep on giving medication. Patient loses blood and ultimately going to irreversible shock. So before that only, if it is necessary, you should think of surgical management. And if you have facility, as I told you, you can think of all conservative treatments, not only in PPH, in AUB or in this thing, fibroids, all cases, conservative managements are costly. They have to be followed up and the results are not 100% sure. So you have to explain the patient, use it. So if you want to avoid surgery, do embolization. It's not possible in small center. You say in a remote place where there is a PPH is occurring, you're given the possible drugs are there, but patient is not getting control. You have to do a surgery. So contraindications is patient is medically unfit on that, only that one, and there you have to tell the patient the risk and take the risk and do the surgery if needed, because medical management is not the end of it. The patient is responding to medical management happy. Otherwise, you have to go for surgical management, explaining and taking the risk.
Thank you so much, ma'am, for answering all the questions for our viewers and solving their queries. Thank you so much for that. I would also like to thank all the viewers who have joined our platform and for putting up across their questions to us. At the outset, I would also like to thank you, ma'am, for taking out your valuable time and for being here at our platform and sharing your thoughts and with such a good presentation that you have shared in. Thank you so much for that. With all your last comments, ma'am, we can conclude the session here for today.
And I thank all the viewers for joining in that post-lunch session. And I think whatever I told could be of some use to you. And I hope to meet you more frequently. Thank you.
Thank you so much, ma'am. So with all your due permission, we are concluding it here for today. Until next time.
Thank you. Good afternoon.
Bye-bye, ma'am.